Good morning, everyone. Thank you for coming. Thanks for inviting me to speak. Common to complex, today we're just really going to tackle this in two parts. Bicuspid aortic valve, which you may think is as common and simple as it gets, but I'm going to make it a little more complicated for you to deal with. And then talking on the very complex side about our children who are born with only a single ventricle. Their heart only has one pump, and some of the advances that have been going on in care for those children. So you may have children with hypoplastic left heart syndrome in your clinic, or you may someday have a child that enters into your clinic that way. So I want to show you kind of what we're up to and how we can work together. So focusing on bicuspid aortic valve, there are a few health conditions that affect as many as 1 in 100 people. So this is amazingly common. But let's put that in a little different context. To put it another way, of all the fans that attend a home Michigan game at the Big House, if you could look around and spot them, you'd find more than 1,000 people at each of those home games that have a bicuspid aortic valve or a related blood vessel issue. So that is a lot. I don't have any disclosures. Discussion of off-label medicines, I'll point that out to you. So to tell you a little bit, you were introduced to me as both a pediatric cardiologist and adult congenital. So what is that? One of my patients asked me if I was a family heart doctor, and I guess that's about as close as I can get. In our adult congenital heart program, we have 2 AC/HD cardiologists, Dr. Tim Kotz and myself. We have a fellow, we're training folks. We have 2 nurse practitioners and 2 RNs on our team as well. And Tim and I try and scatter around the state to provide some of those follow-up clinics. I go up specifically to Traverse City and Petoskey. I'll be there next week, so maybe I'll cross paths with some of you. Anatomically, what does this look like? So bicuspid aortic valve simply means that a valve in the aortic position has 2 parts instead of 3. And usually this is because one of the gaps, one of the commissures between the leaflets just fails to unzip as I tell it to the patients. And these pictures are of a couple different conformations that can happen with the sternum to the top of the screen and the spine to the back. You have a couple spots that can fail to open, and we see that as either a right-left fusion or a right non-fusion. You know, if you've really looked into this, the question comes up sometimes, well, what does it matter which they have? And for an individual patient, I would argue that it really doesn't matter. There are some trends on what those are associated with or which one may be more severe, but for that individual patient, we just need to see what they themselves, how the valve is working, what they themselves have, and how we're going to follow it up. Occasionally we have a valve that is only open really as one big leaflet, but we won't spend too much time there. Ron told you that I like echo, and so I'm going to try and put a little echo into this clip. So what do we see if we have a child or an adult come for an echo? What do we see? This valve at first pass in the center of the screen is the aortic valve. It looks like it's going to have 3 leaflets. There's 3 white lines coming together. Like the other speakers, I'll see if I can get a mouse to pop up here. The mouse has been misbehaving and it's doing it again. So let me try. Does that work? So a valve that looked like it was going to have 3 leaflets, suddenly we see that those 2 leaflets to the screen top and the screen right are stuck together. They didn't separate, they didn't unzip, even though you can see where they almost did. You can see the raphe. So that's a bicuspid valve. And we haven't examined it otherwise, but boy, it sure looks like it's opening well here. And in systole, there looks like there's plenty of space for blood to get through. So why would this ever be a problem? What we're looking for are problems with these valves, where sometimes they'll be too narrow, too leaky, or both. And in the center of the screen, as that valve closes, you see just some bright speckly color, and that's just a tiny little bit of leak that's developing in the center of the valve there. So a child with this valve, I would tell them, this valve works as good as any aortic valve ever can. This valve is causing you no problems now, but we need to follow you lifelong to see if that story is true. Because we as cardiologists are lousy at predicting who is going to get into trouble with one of these valves over the next 10 years and who's going to be looking exactly the same 10 years from now. This is a view from the side. Apex of the heart is to screen left, base of the heart to screen right, and in the center we're now looking at that aortic valve from the side on. And you can see that when the valve opens, those gates just don't quite get out of the way. They're kind of, we call it doming. They don't open up quite all the way, and you can see where an issue would develop if that was even worse. All right, I love echo, but I'm going to try and leave it behind after this clip here. That jet coming back toward the mitral valve and toward the left ventricle is another example of the way that a valve can leak. And so aortic valve leakage, directed down at the mitral valve there can sometimes even cause us changes in how the mitral valve is operating too. So that's what it looks like. We know it's common and that there's just this risk profile. We're going to say that they're at increased risk for developing narrowing or stenosis of the valve, insufficiency. Any three-part valve, a normal valve as we would call it, could do the same thing. This is just a little bit higher risk. It doesn't mean that this valve is destined to fail. And so parents will come in believing that their child is on the cusp of something bad happening. And I say there's absolutely nothing to say that this valve isn't at 80 years of age going to look and work as well as anyone who has a three-part valve. We just need to watch. So current update, what about endocarditis? Endocarditis for bicuspid valve, is there an increased risk? The answer is probably there's a slight increased risk. Do antibiotics before dental work reduce that risk? Probably not, probably not. So the current recommendation is not to give antibiotic prophylaxis for someone with bicuspid valve who, importantly, has not had endocarditis in the past. So if they've had endocarditis in the past, that gets them into the club still. They still get to do antibiotics before dental work. What about our patients who have had antibiotics their whole life, every time, and that have a desire to continue to do that? Or a dentist who believes personally that this is helping their patients and the dentist wants to promote it. I think we can point them toward recent data, including from Great Britain. So Great Britain, about the same time we changed practice in 2007, 2008, actually a few years before that, made the change in recommendations. What's different there is here, the recommendation change, that didn't necessarily mean that we changed practice. There, the pharmacies had control over this, and so they had a definite change in practice. And even in that environment where that really went into effect, we have not seen an increase in endocarditis as a response to that. So I think we can work toward reducing antibiotic use in this group. Okay, I have to pause now and keep my word to one of our attendees. So I said I was going to ask this question. This is an active audience response question here. How many of you think that the temperature in this room is perfect right where it is? How many of you think it is too hot in this room? How many of you think it is too cold in this room? I say, okay. You guys are a great audience. This is fantastic. So we're going to work. We've got a thumbs up in the back. So we're going to work on that. People with bicuspid valve have a similar sensitivity to temperature as the rest of us. So that's now part of the talk. If you're in an off-site, you're going to have to talk to your people there about how your room is, because I don't control that one. So is this an isolated condition that just affects the aortic valve? We can hear some things on physical exam if it's an aortic valve issue. We can hear stenosis, we can hear leakage. But the problem is this is not an isolated valve issue, and this is really a development in our understanding of bicuspid aortic valve. So not only is this a valve condition, but the ascending aorta somehow in development is linked. And I can wave my hands and say, neural crest cell migration and some other things, but we don't quite understand it. But the ascending aorta in the chest is at risk for dilation in somebody who has a bicuspid aortic valve. That could be the sinus of the aorta, the tubular part. You'll see reports that refer to the root, and we have to try and parse out what that means. Why is it? Maybe it's hereditary tissue differences. Maybe it's a hemodynamic effect of aortic stenosis. Probably there are elements of both. But we know that this can happen, this aortic dilation can happen just like those echo pictures we looked at together for someone who has a bicuspid valve that works beautifully. They can still have a dilated aorta, so the whole story can't just be in stenosis of the valve. Here's a schematic of an aorta. The picture starts at the aortic valve, in the main picture at the bottom there. An aortic valve with its three sinuses to it, the coronary arteries coming off. We're going to call that the aortic sinus, the aortic root, I would refer to that. The ascending portion heading up we can call the tubular. And we can talk about the aortic arch or the transverse aorta, all synonyms. And there are different patterns. Patients can have dilation that just occurs at the sinus or just occurs up in the ascending portion near the arch where it's actually harder to see. A couple diagrams to kind of wrap our heads around why this could be and why those different fusion patterns might matter. Those different fusion patterns in a stenotic valve are more likely to direct flow against one of the walls or the other wall. So maybe this is part of the story. But enough to just think this is not a valve issue alone. This is valve plus blood vessel. How about in physical exam? We can hear that systolic click before the flow starts. That valve opens up. If we remember that echo picture from the side, that doming happens, just like two different sailboats there that can pop. And as that leaflet gets filled with blood and the pressure goes up against it, that's what's creating that systolic ejection click. So you can listen for that. You can listen for the murmurs of stenosis or insufficiency. You can watch those blood pressure differences between the systolic and diastolic. You can look for all of those things. But you have nothing in your toolbox, a physical exam, that can point you toward ascending aortic dilation. That is clinically silent. Some would say maybe that S2 is going to be a little bit prominent, but even as a cardiologist who likes to say 1 out of 6 murmurs and things like that we pretend like we hear them, this is something that I don't think we can hang our hat on. We're not going to hear this S2 that's prominent. I'm going to point out a few papers and resources along the way. This is a 2014 AHA-ACC guideline. It's written for adults, but has some information that is helpful to us. They stage valvular aortic stenosis, and they have a group that I think is important to remember, which is just the at-risk group. And bicuspid valve is going to be there. And then they have a progressive aortic stenosis group, and bicuspid aortic valve is going to be in that group as well. And that will then connect to how often should we be following these patients, and what do we do in follow-up. Well, this is most likely going to affect you, because if this has been found in one of the patients or family members, one of the parents or family members of your patients, they're going to ask you, what do we need to do for this child, for this infant, school-age kid, adolescent? I think the answer is a little bit different. But now that we recognize it's not just valve, but valve and aorta, we've figured out that the inheritance pattern is stronger than we thought. So if we count any aortic dilation or bicuspid valve in the family as being part of this whole deal, we don't know what the genes are, but it seems to follow an autosomal dominant pattern with variable penetrance, somewhere between 10 and 20%. So as many as 1 in 5 of the first-degree relatives are going to have part of this complex. So that's parents, siblings, future children, 1 in 5. And as you start hearing about the family story, some things will bubble up to the surface about the grandfather who died of an aneurysmal rupture of the aorta, a second uncle who had an early valve replacement. Maybe this is part of the same percolating bicuspid aortic valve pathology that's percolating through the family. So what do we say then? If it's 1 in 5 of a condition that affects 1 out of every 100 to 200 people, that is a lot of people hanging out in that football stadium that we're going to say should be screened. And that is where the controversy arises. So there is still controversy about, for something so common, what should we do about it? Based on expert consensus at this time, the answer is that if there's a history of a symptomatic or pathologic bicuspid valve or of a dilated aorta, all of those first-degree relatives should be screened with an echocardiogram. Some would advocate that if it's an isolated bicuspid valve that's functioning great and there's no aortic dilation and whoever in the family is already known, that you not screen them. But I will tell you that right now, until we learn more, I think the answer is, in my clinic, every first-degree relative is recommended for screening. There's a problem with cost. There's a problem with lack of proven benefit to early recognition. So the following question is, well, how early, at what age, should we screen by echo if we're going to screen? There is no emergency here. If you are seeing a child that has a first-degree relative, parent, sibling with bicuspid valve, you examine that child, and they do not have significant valve pathology on your exam, there is no emergency to get them screened for the ascending aorta part of it or mild aortic insufficiency or stenosis that you've missed on your exam. In fact, I would say that waiting, if you're looking at an infant, waiting until definitely the child can be have an echo completed without sedation is in their best interest. So I don't think that between those ages of 1 and 3 or 1 and 4, for a child with a reassuring exam, you need to send them for a sedated echocardiogram. I think you can wait till that child can go through a non-sedate echocardiogram, which, depending on the child, maybe 2.5 in some of these kids, but maybe age even 4. The likelihood that they are going to have a significant aortopathy that puts them at increased risk of aneurysmal rupture that early in childhood is extremely, extremely low. But more to come on this, more to come. Next, we order it. Now we have to try and get it paid for. And these are some of the appropriate use criteria for echocardiography that we use to support our orders for echocardiograms. So another document that's out there that says, when the insurance company balks, you can say, well, here is the guideline that says it is reasonable to screen a child who has a parent with bicuspid aortic valve, even if there are no signs and symptoms in the child. This is another guideline from 2008 ACC. This is an adult congenital guideline, but it says first-degree relatives, let's screen them with some evidence behind it. I would caution you as you talk to families that you remind them to check with their insurance company about what their copay is going to be. Because if the insurance company has a 20% copay, and like me, you send a family with 5 kids off to get their echocardiograms, that is a large bill that is going to come to this family at 20% copay per echo. And so we try and go into that with the families being eyes wide open and also saying, all right, if we can only do 2 kids this year, we're going to do the 2 oldest kids. We're going to wait a year, do a couple kids in the following years. This is not an emergency, but we do want to figure it out. The aortopathy, the dilation is progressive. There's a risk for dissection and rupture, and we follow it like we do other aortopathies. What does that mean for adults? It's greater than 55 millimeters. The prior guideline was 50. Or a sudden jump of 5 millimeters in a year for someone who already has a dilated aorta. There's no consensus for what those cutoffs should be for pediatrics at this time. Medical therapy, this is going to be a little controversial possibly as well. There's no evidence of benefit for medical therapy for a bicuspid valve and associated dilated aorta if there's a normal blood pressure. So we want to treat these kids or young adults to a normal blood pressure. There have been attempts to use beta blockers, angiotensin receptor blockers to bring blood pressure, even if it's normal, bring it lower. That is off-label. That has not been supported by data to this point. I will tell you there are a number of my colleagues who would still advocate using beta blockers, and I can just say there's not evidence of benefit at this time. Treat hypertension as you would for any child. We're happy to collaborate on that, but standard criteria, no special criteria. And we talked about antibiotic prophylaxis already. Okay, you have a child in your clinic. They're known to have bicuspid valve. You know something about their aorta, and they want to play sports. What do? Big picture, there is a change in our thinking from what you cannot do, what you need to be excluded from, to a really trying to encourage and empower families with what is acceptable to do. Please get out there and be active. Here are some of the criteria at which you can be active. Here are some of the sports that we encourage you to do. So we're trying to flip that and actually giving out those exercise prescriptions and know that you are doing likewise. There are guidelines for eligibility, recommendations for competitive athletics. This is a title that is important to pause and think about. We really do mean competitive high-end athletics. We don't mean rec league, low intensity, able to step out at any time. We mean kids that are really going into high-level club, competitive school, where they might push themselves really to their limits. That is what this guideline was referencing. This is not a let's go play in the park or let's grab some friends and go down to the ball diamond. This is beyond that. So there's a subset of this guideline referencing aortic diseases. Summary, no restrictions if the aorta is a normal size and if there's no significant valve pathology, meaning the valve works well, the aorta is normal size, free reign. We're not going to restrict them in any way whatsoever by this guideline. Restricted to moderate, static, and dynamic, and we're going to talk about what that is in just a second. If they have mild dilation of the aorta, we may try and have them avoid some of the very high-end activities. And if they're near a cutoff zone, we may increase our frequency of evaluation or even involve MR angiography if we can't see the aorta well. So people have worked on this table over time. The y-axis is static component, the x-axis is dynamic component. And so there's a grid associated with this guideline that says, all right, what sports typically have higher static? And at the high end of that, if we talk about high static, bobsledding right at the top. I know you guys have a lot of kids that want to get out and bobsled. But probably the one down near the bottom there is the important one, weightlifting. So we have a lot of folks who are weightlifting and they say, I want to weightlift and I want to weightlift big. How do I do this? At the other end of the spectrum is high dynamic. So not a lot of weightlifting type of maneuvers, but really going hard like the running, soccer, etc. And then there's some sports that combine those two, rowing, biathlon, things like that. So why is static an issue? Static is an issue because when you lift hard weights, you lock your gut and valsalva, you raise your blood pressure quite impressively. So we want to avoid, by common sense, we think that avoiding very high blood pressures on an already dilated aorta may decrease the rate of dilation. We do not have proof of that. This is expert consensus and trying to apply some common sense to cardiology. High dynamic likewise. So I'll tell you what I tell my patients. I say you need to always have an out in your sports. If you need out to take a break, you need to have that. Everyone who's been part of that, coach, parents, etc., need to know and give that kid the option of having the out. I need to tell the child that no matter what their peers are saying, that they can have that out. Weightlifting, high repetitions, lower weight. You should be able to do 15 reps of any maneuver, 12 reps of any maneuver before you go to failure. You shouldn't be locking your gut and doing a 3-rep max set. Shouldn't be graded on the max weight you can lift. Your coach shouldn't be pushing you to that. And high dynamic, if you have enough breath that you can carry on a little conversation with your exercise buddy, okay. If you're pushing yourself to where you don't even have enough breath to talk, you're probably pushing too far. An association just to remind you of, something that is lurking out there that we find every now and then, missed early, is the link between bicuspid valve and coarctation. This is of those with coarctation, 50% have bicuspid valve, but of all those folks out there with bicuspid valve, 6% have coarctation. So we're doing all these screenings trying to find coarctation early, but I'd like to show you some pictures of an aorta. On the screen left there, that's the aortic arch that tapers down to just a pinhole to the descending aorta. This was found in my patient at about the age of 50. The picture on the right is a pulled back picture of the vasculature for the same person. And all of those curlicue vessels are an amazing number of collateral vessels that they've developed to bypass that near complete interruption of the aorta. How they survive this in infancy is still a mystery to me, but we find these folks. They're lurking out there. And so when we see kids with hypertension or we find a bicuspid valve, we want to just keep in mind reaching for those lower extremity pulses and making sure we don't have this associated coarctation. Long-term follow-up is appropriate. We want to modify risks like avoiding smoking and blood pressure and all those good things. So take-home points here. It's common. It can be silent. It can be in first-degree relatives. We want to screen those relatives, but keep cost in mind and know that this is not an emergency. And take-home points beyond this, there are very few cardiac conditions that are fixed or cured, even in spite of our best surgeries at this point. So putting on my adult congenital hat, we need to have lifelong follow-up, minimizing gaps in care. And we know that when we lose patients to care in cardiology clinic, many of them maintain care in primary clinics. So you have a chance to point these folks back into cardiology to continue this partnership. And I'm going to shift gears here for just a second in the last 3 minutes, and we'll stay on time. I want to shift to the complex, the single ventricle. So how many of you have collaborated with us in the care of a child, an infant who was born with a single ventricle heart, has gone down? That is fantastic. I don't know how recently that's been for you or those of you who may be approached to do it in the future. But single ventricle anatomies maintain one ventricle that's pumping blood to the whole body. There are really many reasons why primary care and cardiology have to collaborate on the care of these patients. I've included some pictures that are going to be in the slide set. We're not going to go over those together, but if you really enjoy this and you want to try and track in your mind how this blood flow is going to go if you only have one ventricle, those are in there for you. But this is the important thing to know. The early period, those first few months of life, unfortunately, are still, in spite of everything that we have done, are still a period of high morbidity and high mortality. And this is a survival curve. This is a curve of death looking at a couple different ways to tackle hypoplastic left heart syndrome. And I don't want you to pay attention to the difference between these lines. The difference between the lines is not significant, but there we are at 3 to 4 months heading into the second main surgery that these children are going to have, and we have somewhere between 20 and even 30% mortality. That mortality can be affected by good partnerships between those lines going up and down, or the different stages of surgery that this child needs to go through. So the key term is interstage. We have an interstage team that is following those children through that period of highest risk And we will invite you to really join with our interstage team to follow through a home monitoring system. It's been found that if we send these kids home with scales for weight, with oxygen monitors, that we can have kind of an early warning, early detection system for children who are deteriorating that may be at risk for sudden death. And that is why we'll work with whoever is assigned as the primary care provider to set up criteria, to set up a follow-up schedule, to have somebody 24/7 who's available to you as a cardiologist. And that doesn't just go for this, but especially for the interstage. They go home with all kinds of phone numbers for contact. But if all else fails, 24 hours a day, you've got somebody through M-Line that's a pediatric cardiologist who knows about the interstage program, who can partner with you to figure out what this child needs done. This should all be done prior to the kid being discharged. You should never be surprised with a child who has a single ventricle just showing up in your clinic. If there's a failure in that system, we need to talk. That plan should be in place, and we do phone conference calls with the family, with the primary doctor, and with the cardiology team, all working together to take care of these folks. Low threshold for in-face reassessment with the primary care team or with cardiology. We aspire to more than survival. We have executive function differences between our kids who have congenital heart disease. These are different areas of executive function, and just one study showing that these folks with congenital heart disease really do have increased risk for struggles from a neurocognitive developmental standpoint. And so for my last pitch, aspiring to more than survival, we do have a neurodevelopmental clinic that's available for any child who had heart surgery in infancy. So any child who had heart surgery at age 1 or younger, we encourage them to come back at any age to come to our multidisciplinary clinic to try and work on assessing them and then putting in place interventions that we can find to try and just maximize the outcomes, because it isn't just about survival, it's about really how these kids do long term. Thanks for your attention.